And the one big thing I often get asked about eggs, so I'll address it here. So eggs, we know egg yolk, right, is high in cholesterol. And so oftentimes people ask me if my cholesterol levels are high, should I be consuming eggs? So it's interesting. In the studies on this, we see kind of a spectrum, but what seems to be the case is that most of us, when we consume cholesterol through diet, it doesn't significantly affect our cholesterol levels. But there are estimated about 30% of people, I believe, who may be affected by the cholesterol we consume. Also, it seems that as we get older, we seem to be more negatively affected by this as well. So I tell my patients who have multiple eggs a day, especially if they're at this higher risk, just don't have as many yolks. Have all the egg whites, but don't have as many yolks so that you can reduce that amount of cholesterol that you're consuming. But most of the cholesterol in our body that we have, it's actually cholesterol that we produce ourselves, as opposed to what we enter into our bodies through diet. It's really the saturated, the ultra processed, like that's the stuff that we have to be very cautious about when it comes to somebody who already might have some of these risk factors. And then we want to do anti-inflammatory foods. We want to do fish high in omega-3 fatty acids. We want to
Yeah,
consume
anti-inflammatory diet.
exactly this.
More vegetables versus protein. I mean,
Exactly.
animal protein.
Exactly. We still want to hit our protein goals, but it's really, really important that we are consuming, pla- the greatest amount of data, because we've had all these dietary trends and everything, and again, there's no one size fits all. But the greatest abundance of data is really for this anti-inflammatory Mediterranean diet. And what is that? It's plenty of plants. It's very high in vegetables. It's high in legumes as well. It's high in lean protein, nuts, seeds, olive oil, extra virgin olive oil. And then, from time to time, there may be other components of the diet, but again, really focusing on these things. And so oftentimes we'll recommend to our patients some type of variation. And again, some people may have certain intolerances and so on that we have to work around. But that really has the greatest abundance of data when it comes to lowering that cardiovascular risk, lowering risk of diabetes, long-term weight benefits, and so forth.
Mm-hmm. So let's say that we have a perfect patient or a person who's like very proactive, like with the health, and she goes to do the right blood panel. She works out. Uh, she does right nutrition. She exercise. If there is like anything else she's missing in her like, let's say, longevity heart prevention protocol, or pretty much like this is it.
Yeah, so a couple of things. So again, depending on the age of the person, right? So if we're talking about premenopause, again, lower risk, lower likelihood that we'll find anything on imaging. And so I typically would not do imaging on somebody who's, let's say, in their 30s, unless they have some very, very significant risk factors like
Imaging, X-ray.
imaging. So yeah, so I'll get to that. So it's actually CT scan. So what we would do for somebody in their, so again, depending on their risk factors, but typically I start having these discussions with my patients in their 40s. But coronary artery calcium scan. So this is a CT scan that provides visualization of the blood vessels of our heart. And so it provides information about whether we have calcified plaque in the arteries of the heart. If we do, this confers a higher risk for developing heart attack or some other form of cardiovascular disease down the road. And so if we see that, and we do have to employ more aggressive interventions. So at that point, I'll say, okay, well, even if the lipid panel looks good, it seems that for your body, it seems that we need to be even more aggressive and get that LDL even lower, that ApoB even lower, and really control those risk factors even more. So coronary artery calcium scan, that's part of our guidelines in helping us guide, those, especially those intermediate risk individuals, whether they should go on statin therapy, cholesterol lowering therapy to reduce their risk. Another test that's even higher resolution and gives more information, but unfortunately it's more expensive, a little bit less accessible, is the CCTA. This is the coronary artery CT angiogram. And What this provides is it provides, and if you do it with an AI algorithm called Clearly, you actually get even more information and visualize all the blood vessels and where the plaque is. And this one, it has a higher resolution for visualizing calcified plaque, but it also gives us insight into non-calcified plaque. So this is the plaque that starts forming before it has calcified. So
So
it
it's with CCTA with AI.
yes, so CCT, so the abbreviation is CCTA, this coronary CT angiogram with Clearly algorithm, exactly. And so the radiologist will still read that and provide a report, but then we also get the Clearly algorithm, which provides us with information about exactly where the plaque is. It provides us about the type of non-calcified plaque, and it specifically tells us about some of the high-risk plaque that we can't visualize on the first scan that I said.
What about this test I mentioned in the beginning of our conversation when you wear a monitor for the whole day and it basically tells you like how old is your heart, like how it's functioning? Is it something that also could be practical, or the CCTA with a clear algorithm is much better?
So with the imaging, you are really seeing what's happening anatomically. So if we want to understand if there's the burden of disease that's bubbling up, that's starting up, that's really one of the best. I mean, the best way to visualize it if we do an invasive study, but obviously that has inherent risk, but we don't do that in people who have no symptoms and so on. But so this is the best way as far as the imaging study to actually see, okay, what is going on. And there are other ways as well to assess heart function, do echocardiograms, stress tests, and so on. But again, we typically would do this in people who have symptoms or who have something that might make us think, okay, let's look at your heart valves. Let's look at and make sure that your heart is pumping normally and so on. But when we're just talking purely preventatively in somebody who has no symptoms, maybe they have some risk factors and we want to be proactive, typically those are some of the tests that we would order. Another one is carotid ultrasound, which is an ultrasound, so no radiation, of the carotid arteries of your neck. And so that also can
Corona ultrasound?
a carotid ultrasound. So carotid is CAROTID. And carotid arteries are arteries of our neck. And so if we start to see that there's some plaque formation there or changes in the blood vessel there, that also tells us there's some disease starting up. We really should be more aggressive. And so these are the patients, when I visualize something on these studies, this is where I want to be especially proactive, set a lower goal for their LDL numbers, for their ApoB, really make sure they have no inflammation. And there's some other inflammatory markers that we can look at as well. I didn't mention all of the labs, but I mentioned some of the key ones. But so this is something that can guide us. In terms of the monitor, I'm not sure exactly which monitor you're referring to, so I may not be familiar with that. The setting where we would typically get a monitor would be if somebody is saying, I have heart palpitations or my heart feels like it's beating too fast. So it's a Holter monitor. It's a little bit different. It looks at the electrical activity of the heart and if there are any abnormal heartbeats and so on. But I don't think that's what you're referring to. So I'm not sure what, yeah.
Do you think that, like, for example, we've been talking about, like a medicine 2.0 and medicine 2. Like 2, 3, like what we kind of
2.0,
like,
3.0, yeah.
yes. So now, like, we started finally seeing the shift, like in a medical care and like the approach and everything. And we started talking about the prevention. And for example, a lot of places, they offer like a yearly checkups where you come, like you can do colonoscopy, you can check your heart, you can check your eyes, you can do the blood work and everything. Do you think that all of those tests we just discussed, do you think it should be a part of the annual yearly checkups?
Yeah, so it really depends on the individual in terms of the blood work. So yes, in terms of annual blood work, like all of the labs that I mentioned in terms of lipid panel, checking for diabetes, insulin, fasting blood glucose, all of those ones that I mentioned, yes, I do that annually on my patients. One exception is Lp(a) that I mentioned. That's one part of the lipid panel that typically does not change over the course of the lifetime, although some things can change it. So if somebody is a low risk area versus high risk area, we know, okay, this is where you are. And that's another separate risk factor that currently we don't have a medication for, but that's in development. And again, there's a lot of research around that. But that would be one marker, for instance, that I would check on an annual basis because it's something that we don't expect to change. The rest of them, I do check them annually. As far as the imaging goes, again, I really risk stratify patients, meaning that, again, if somebody is coming to me and they're in their 20s or 30s and they have no severe family history of, we're talking very, very early heart attacks.
But what if for something that I've heard from like doctors or colleagues, sometimes like supplements can harm us. Like when person takes too much of vitamin D without vitamin K2, vitamin D drives the calcium into the vessels, and this is how like the calcification of the heart vessels like might start happen. Even someone who doesn't have the genetic predisposal, even someone who does lots of sports and activity, eats well, but just because not very smartly supplementing themselves with the vitamin D3, it can really, like create this extra calcium. So could you comment on that, please?
Yeah, so it's interesting. So I always recommend vitamin D3 with K2 for that exact reason, that vitamin K2 helps to drive that calcium that, again, vitamin D supports absorption of it. So vitamin K2 helps to drive that calcium to the bone instead of the arteries of the heart. We also want to be careful about calcium supplementation because, again, in my patients with cardiovascular disease, even though it's important to hit certain calcium goals for our bone health, that's a whole other topic, right? But we have our recommended daily allowance for calcium for bone health. And this is in particular important for women after menopause, the risk of osteoporosis and so forth, but for men as well. Men can certainly have osteoporosis, and I do see this in my clinical practice too. But what's important, especially for people with cardiovascular disease, that they're getting all or at the very least, most of their calcium through diet, because calcium through diet does not seem to confer this increased risk of calcification, but excess calcium through supplementation may. And so this is where we want to be cautious about that calcium supplementation too.
So women, like premenopause with osteoporosis, they should be taking vitamin D3 and they should take like K2 100%. So it's
So
kind
what
of. Mm-hmm.
Right. Yeah. So good question. Yeah. So what I do in my practice is I monitor vitamin D levels, right? And um, so we want to make sure that we hit certain goals. And again, by definition, vitamin D sufficiency, meaning enough levels of vitamin D, would be 30 nanograms per deciliter, and or above. And we certainly don't want to go above the upper limit. And depending on the lab, it might be greater than 80 or greater than 100. And this is also when we can run into issues, because if we run into very, very high vitamin D, which can be harmful, sometimes, I hear people taking very, very high doses, and it's very important that they get their vitamin D monitored, because that can absolutely cause elevated blood calcium levels. It can actually even increase risk of kidney stones. It can cause constipation, psychiatric abnormalities in high amounts, and so forth. So definitely monitor that. And then for me in my practice, I generally like my patients a little bit higher in terms of vitamin D levels, just because we know about its levels on the immune function, immune system regulation. We also know about some of the associative studies with respect to certain cancers and vitamin D. So I do like to, and autoimmunity and vitamin D and so on. So I do like to keep my patients a little bit higher than that 30 range, but certainly not in those upper limits where they can be at high risk. And vitamin D is a fat soluble vitamin. So the problem is, unlike, let's say you're taking B12, I still want my patients taking B12 to be in the correct range, but I'm not as worried when their levels are high, because they're just going to excrete those extra levels. But vitamin D is a fat soluble vitamin, so it gets stored, and it takes time for that to normalize then.